Good morning, everyone. I think that we see so much of newer technology and newer combined modality treatments for all these malignancies that we are now treating. But I think what we need to remember is that we just don't need to treat, we need to see what is the quality of life that these patients are living after the treatment is over. Because that is something that we are not really concerned about initially, when our aim is only to treat the patient and cure the patient. But these patients survive longer, and therefore the quality of life in these patients is very important. And to address this, it's a very nice session to have. The first topic that is going to be there is radiosurgical hypophysectomy, a way beyond the last step of double bridge ladder. May I please invite Dr. Manju Tripathi for this.
Thank you, Chairperson, and thank you, audience, for coming for this palliative session, which is actually one of the most neglected sessions in any kind of a conference. As you rightly told, in the last 3 days, we have been studying about various IMIBs, MABs, all those drugs which increase your overall survival, your progression-free survival, and all those things. But during my journey in neurosurgery as a doctor, I found that the most common reason for any person to come to a hospital is actually the pain. It might be a headache, it might be a pain because of your broken heart, it might be a pain because of your slipped disc, but that's the most common reason any person comes to the hospital. So as these patients are living longer and longer because of these targeted therapies, there is a significant patient population which is having a pain which is adversely affecting not only the quality of life of that particular person, but it has an impact on the psyche of the whole family which is treating it. So these are my disclaimers. What is the status of the burden of this disease? If you look, nearly more than 50% of these patients are in the advanced state and they are in the severe pain. Out of these, 70% patients are actually addicted to the morphine to take care of that pain, and even 30% or more than those patients are actually resistant to the morphine. And this pain, for which WHO has defined a ladder, might be because of the primary cancer, but mostly it is because of the bony metastasis of these pains. This is not soft tissue metastasis, but the bony metastasis which causes the pain. Sometimes it is because of the systemic therapy which the patients are receiving. So this concept, somehow we knew, even our ancestors, our forefathers in the medical field knew that the pain pathways have some channeling through the hypothalamus, hypophysis. And they knew that if we target that, the patient gets relief in the pain. So they gave a term like the hypophysectomy, but is it really an androgenous destruction of the pituitary pain, the goal of the pain relief? It is not an ectomy in its literary terms. So the other terms have been given like the pituitary neuroadenolysis, pituitary pain radiosurgery, or the pituitary neuromodulation, by whatever the way you are trying to do this. And this was first tried in 1953 by Ruth and Oliver Bruna for the patients who are having hormone-sensitive breast cancers and the prostate cancers, and in those patients they found that all patients had a significant pain relief without any morphine when they went with the transcranial route, and those patients for the rest of their life didn't need any surgery. Some tried transhysterectomy as well. But in 1970s, we got a hysterectomy frame, and with those ones it became very easy to target the pituitary hypophysis, and chemical hypophysectomy with alcohol became a very routine in those times. And it gave excellent results. People also tried the radiation techniques, cryoablation, thermoablation, but the alcohol was the one which was easily available and the patient had a good pain relief. If you look at the literature at that time, these are all the alcohol which were given by the transhysterectomy route, and most of the patients had a significant pain relief for the rest of their life, but that came with some complications. So the pain relief was good. There was complication related to the CSF rhinorrhea, meningitis, and many of those patients actually suffered from mortality as well. So, Professor Lars Drexel thought that is radiosurgery a technical alternative with a sharp dose fallout, with a sniper shot at the neuroadenohypophysis. They started it. And if you look at these series which were in the 70s when they were targeting it on the basis of the angiographies, they found that all patients who were treated with a higher dose had a relief of the pain in 100% cases, but there was a complication of the hormonal deficiencies in those cases. Nearly 3 decades passed on, and there was no resurgence of this technique. But again, people got interested because there are limited options for these patients, and they are really in pain. So Hayashi they started doing now with an MRI and CT guided pituitary hypophysectomy, and the results were pretty good. Patients who had a malignancy related pain, their pain control was much better in comparison to the patients who were having an atypical facial pain on the non-malignant case. This was a resurgence in the era of the pituitary radiosurgery. Most of those patients are actually the cancer-related pain. They also tried the thalamus or sometimes the post-stroke pain, and they found a significant pain relief. 100% pain resolved without significant complication within a week of the stereotactic radiosurgery, and it was prolonged for the rest of their life. At a follow-up of 1 to 24 months, there was no recurrence, so there was no hormonal damage to those patients. How does it actually work? We just have the hypothesis, we do not have a conclusive evidence how does it work. Probably it has something related to the oxytocin. When we target it, probably the oxytocin is shifted to the hypothalamic region, which provides you pain relief. There are studies which show that the beta endorphin levels increase over there, but given that naloxone doesn't have an analgesic effect up there. Since it is more effective in the hormone-sensitive metastasis, people have tried it in the estrogen and the progesterone blood levels. But all these are just speculations, these are the theories. I do not have a conclusive answer or a pathophysiology to show how does it work, but it works. Then there is another question, is it really a destruction or is it a stimulation? Is it a neuromodulation because of a pituitary high-dose radiosurgery? Because if you do the follow-up radiology, even in patients who live for the longer duration of time, there was no lesioning seen over there on the MRI. And these patients who are in the range of the kPa 40-50, they start getting their appetite back. They gain an overall improvement in their weight. If you do an MRSS studies, there is an increase in the N-acetyl aspartate, which is suggestive of increased neuronal activity. So probably it's a radiosurgical stimulation rather than lesioning with this high dose, which is possible with the radiosurgery. Where should we target? Where is the sweet spot? The sweet spot is usually at the junction of the neuroadenohypophysis and the pituitary stalk. And if you target it with a sniper shot like a 4mm shot with a 160 gray, you have a good dose fallout, preserving your optic apparatus in those cases, and you can have this effect. This is the coronal and the ciliated section of the same area, and you can see that this is the dose fallout. These are the optic apparatus, and we are in a pretty safe range by targeting these ones. Why is it necessary? As Madam already made the background for my talk, I am sincerely thankful to you, Madam, that it's not only just the length of the life, it's the quality of life. The life should be worth living. And a person whom you are taking care, if you have seen the prime of their life, struggling them, seeing them struggling with this pain is actually painful to the family as well, I think. Apart from all those chemotherapy and other regimes which you are trying, this is a very important aspect which you need to take care while you are treating these patients. Then there are certain questions like, does it only work when there is a hormonally active metastasis, like from the breast or from the prostate? It has been found in the limited literature that it is more effective in the hormone related, but it's not that it doesn't work in the other metastasis. It works well. There is a slight difference, but that also is not statistically significant. It also works in the non-malignant thalamic pain. People have tried it, like in a stroke, but for those pains I find that the thalamus is probably a better target to treat for the non-malignant pain rather than pituitary. Pituitary is good for the metastatic pain. If you look both at the short term and at the long term, if you treat with the pituitary, the long term pain relief is so significant, 87% here, 90% with the long term pain relief, close to 90% compared to the thalamus, which have better results in the non-malignant pain. And pituitary has significantly less effect in the non-malignant, like the stroke-related pain. These are the published literature over radiosurgical hypophysectomy, like the CFS with the bone metastasis malignant disease. People have also tried it in the cerebrovascular disease, but I have already told about the results. The adverse effects in the current series, which have been published since 2002, it has been proven a very, very safe and effective treatment. The problems with the prior series, they were treating it with pretty high dose, which was against the Lawrence policy. They were going by 250 day, 220 day. And in those era, when the CT was a rarity, we couldn't think about the MRI, we were just treating on the basis of angiographies. In those cases, there were hormonal deficiencies. Now in the later series, out of all those patients, I could find only one patient who had a diabetes insipidus and thyroid deficiency. Otherwise, the rest of all the patients didn't need any hormonal supplementation despite targeting pituitary with such a high dose. So, in the today's time, there are small non-randomized prospective trials which are giving us sufficient evidence to support a radiosurgical hypophysectomy for these patients. There are limited descriptions of the types of the pain treated, but at least with the hormonally active metastasis, this is definitely there. And there are two prospective trials which are ongoing, like one from the John Regis group from the Marseille and another is from the Hopkins. I personally discussed this issue with Regis, and this was his protocol which he published. If somebody wants to start this trial at their center, this is a very, very robust, very pragmatic trial. You can actually go with it. And he told me that within 24 to 48 hours, people will start getting a pain relief, and that sustains for the rest of their life. Whenever I tried discussing it at multiple forums, people ask me what is the level of evidence. For most of the things in science, we are having an evidence, but equally important are the studies or the drugs and the notions which we follow. We do not have an evidence, but still we practice it because we have been seeing that effect for close to around 4 to 5 decades, like the role of the menthol in the hand disease. Nobody could do a study falling from an airplane without a parachute, but we know that the parachute works. Similarly, in the trigeminal neuralgia, we are never sure about the pathophysiology, and there are different streams of treating it, and all have proven some of the other effect. And this is one study which is repeatedly being shown good results over a long course of time, and probably we are going to get a level 1 evidence in the next decade, but still we have a sufficient evidence. If we do not follow this, there are restricted rules to the opioid rules. They are not easily available, and there are very strict rules to give to the patients, and most of these patients are suffering with the opioid-related addictions and their side effects. So it's a very effective and safe alternative for the patients with incurable malignancies in the terminal stages of their disease with a KPS more than 40, more than 4 weeks of the life expectancy. Patients who are resistant to conventional treatments and the other WHO schemes. It has a significant improvement in the patient's quality of life. Yes, we should be very careful because we had a checkered history of the psychosurgery, and the people are skeptical about it. So evaluate these patients, but do not continue with your prevailing nihilism which we have been having in our mindset for the last 7 to 8 decades. This is a modality in your kitty. It is a part of your armamentarium, and please use it. This is a very safe event. You already have an evidence. I am not showing a hypothesis here. I have a clinical evidence over it. And I use this forum today so that you can get sensitized that this patient can be treated in your hospital with an available treatment modality already there. Let's not be too much skeptical about it. Those patients do not have any other option now. There are options which have been given like the intrathecal baclofen pump. A patient who is in the KPS 40, who is practically a veteran one taking to a major surgery with a 15 to 16 lakhs procedure treatment. Compared to that, this is just 75,000 rupees, and most of these patients who are actually in the terminal stage, they can be helped with the government schemes, and they can have a better relief for the rest of their time. The current recommendation is 160 day. Junction of severe hypophysection is stopped. Any patient in the terminal cancer stage with KPS 40, more than 4 weeks life, and yes, we are knowledgeable enough about it. So to summarize, it's a work in progress. Definitely there are recruitment difficulties. Why? Because we are nihilistic. From our seniors, from our teachers, they all say that it doesn't work. No, it works. There is evidence. And please try it. The fragile patients in the terminal stage on the high dose of the morphine therapy, the ethical treatment, it is the ethical treatment related to the best medical treatment. It has a very rapid effect on the bony bony metastatic pain. It has less effective for the non-malignant pain. I do not say that use it upfront for the stroke-related pain. And it is very well tolerated. It is much effective with the less side effect compared to the other treatment modalities. Thank you so much.
Thank you very much for this talk. Those of us, I think most of you are not of that area, but from where I come from as residents, this was one of the treatments which was recommended for people with bone metastasis, maybe with hormone breast. We used to do ablative procedures, gammaknife.pgimer, if that didn't work, hypophysectomy. But for all that, the complications were much more. So you have said that with targeted, of course, the complications would be much less or not at all. But I want to understand that how can you say that they are opioid refractory?
I'm not saying that, it's WHO saying. WHO is saying that 30% of those patients become opioid refractory or opioid resistant to to the pain. Their pain is not responding even to the higher doses of the opioids.
Yes, I agree that if you have bone pain, it is difficult to manage it with opioids. But a statement you made saying that they become opioid addicted or something, I think,
Yeah, ma'am.
I don't think that should be a statement which is made, because if opioids are used in the right way, addiction is a very, very, very remote thing for people with cancer pain.
Being in a right way is actually a very personalized and a very custom-tailored approach. It might be right because you are thinking about the doses and you are already vigilant that if I increase that dose, this patient may become addicted and probably he need a higher dose because his pain is not responding to that much dose which you are already prescribing.
No, pain is an antidote for being resistant. If you follow a proper package of care measures. However, I would now like to have it open for the audience. Any questions from the audience? Yes. One second.
Thank you, Dr.
I would like to ask, how many percentage of patients are getting relief? Almost 100% or is there any percentage?
If I go with the French group, they say it's 100%. I remain a little skeptical, but with the overall literature available in the English literature throughout the world, the pain control is more than 90%. 90% of those patients are actually now pain-free without the need of any opioid in those patients. The job is to say that they are practically 100% pain-free for the rest of their life.
Very nice lecture, Dr. Mundu. The pains with the booking metastasis, there is a two type. It is a constant pain and due to the bone compressed fraction. So patients saying when I lie down, sit down, there is no pain, when I'm moving because of the fracture. So we have to decide that, and that situation, we request to neurosurgeon to do the fixation surgery, then we give the radiation. But they are also not convinced. They says the time frame, it is less than 6 months. The patient, they don't want to do even surgery to fixation to that, to relieve the pain, one point. Second, the opioid resistance, we not seen that much. Third, how much number your experience in BJ Institute doing the hypophysectomy surgery and relieve the pain comparison to the opioid?
I'll answer in the reverse way. I haven't done a single case, and that's the reason I'm giving this talk, because I have been discussing, I have been trying, I have been pursuing people for quite a long time. They all know the misery of those patients, but somehow I don't know what is the nihilism and what is holding them back to refer those patients. As you told, I'm also a surgeon. I'm skeptical about fixing those patients because of if they are having a fracture or something like that, because I know that probably he would die before the wound heals. I'm recommending those for the patients who are in KPS more than 40. I'm in discussion with the groups who are doing it, and they're saying that those patients are actually getting a pain relief, so you should also try it. I'm using this mixed form of the radiation oncologist, medical oncologist, and the neurosurgeons because in the end, probably the patient is with you, not with me. I have removed the CA breast metastasis, and then the patient is with you. Now you know the status of the patient, that he is in the pain, so you can refer it to me. The patient isn't in the last stage. So I couldn't do a single patient so far. The second point, why don't we fix? So there are two sorts of a pain. One is just a metastatic pain, which is probably irritating the periosteum of those patients, and that is causing the pain. Those patients are ideal candidates who have a constant nagging pain, rather than the one who are having a pain because of a fracture segment which is irritating over there.
Pathological fracture.
Yeah, pathological fractures. So on those cases, probably we can try with a vertebroplasty or some other sort of a lesser invasive procedures rather than just going with a fixation. And vertebroplasty and sometimes even a focused radiation in your cases to that particular area where it happens, it gives a pain relief. But I think probably they are in a slightly better KPS if they are walking, talking, and all those situations. So a constant pain because of that long bones or somewhere, if that kind of a pain is there, that gives a better relief.
So now I think we should wind up here. So next session is
Thank you.
next session is rescue you how to maintain the quality of life with pulmonary. Dr. Mukti Mukherjee, she is a radiation oncologist in Apollo Multi Specialty Hospital, Toronto.